Welcome. In the second part of outpatient COPD management, we'll focus more on medication use. So before we think about starting medications, we need to also have the ability to stop medications that don't seem to work. So if we do start the patient on an inhaler and they have no benefit after 1 or 2 months of good use and appropriate dosage use, you may want to consider stopping the medication or reconsidering a diagnosis of COPD. The other thing to consider as well is cost. Cost of treatment seems to be going up nowadays, so bear that in mind whenever you start something new. Consider stopping another medication that isn't working and starting them with something new, as opposed to just having one over the other where the previous medication doesn't seem to have any effect at all. So with regards to effect, use a reliable metrics of assessment. Like I spoke about in the first part, you can use a clinical COPD questionnaire. You can also use the COPD assessment test or the modified medical research council scale. Those are usual metrics that you can use to assess changes in their respiratory function. Now the goal before you start any medication is to reduce or minimize the use of albuterol, because the use of albuterol or the rescue inhaler is a sign that their respiratory status isn't within reasonable control. So the patient's still requiring 3 to 4 uses of albuterol a day. This may mean that their COPD is still not well controlled. But another thing to consider is most patients may mistakenly take albuterol every 4 to 6 hours because they expect or they think they have to. So they may not take it as a PRN basis, which they should. The other thing is to improve symptoms. So symptoms such as cough, and shortness of breath and exercise tolerance and so on, and sputum improvement. These are some of the changes that you expect to see in these patients if you think your medication is improving. So let's start talking about medication use. What I normally start off with in most patients is moderate COPD or symptomatic COPD that require frequent albuterol use. I do start them off with the long-acting muscarinic agonists such as tiotropium. There are newer ones in the market which I can't pronounce, but tiotropium is one of the most common ones nowadays, along with the short-acting beta agonists such as albuterol. So that's my go-to start-off medication. Again, whenever you start off any medication, let them know what the side effects are, especially if they have a history of glaucoma or prostate problems and so on. The long-acting muscarinic antagonists may not be the best first choice in patients. Now, if that doesn't work, or the symptoms are still out of control and they've come back to you, I will defer to patients then using the long-acting muscarinic agonist in combination with the long-acting beta agonist. This is a newer combinations out in the market. The brand names are Stiolto, and another one is Anoro Ellipta, and they're once daily use, which is really great for patient compliance. And I factor this in with the short-acting beta agonist for breakthrough bronchospasm and shortness of breath. If that doesn't work, then I normally go on with the inhaled corticosteroid in conjunction with the long-acting beta agonist. These are your usual brands such as Symbicort and Advair, and I add on then the long-acting muscarinic agonist. So this is a stepwise method that if you have the luxury of time for an outpatient, the patient's symptoms are relatively well controlled, you may want to use that way. But in patients that are in the hospital and so on, I normally just jump over to this and start them off with this and do a step down approach as opposed to the step up approach. So step up approach, especially if you're outpatient and you're able to gradually go up. But if a patient comes to you right after hospitalization, and their symptoms are still out of control, you may want to crank it up and then taper it down over the next few months. A few mentions again regarding spacer. You can go ahead and use a spacer, especially if you consider that the patient's coordination or ability to use the MDI or metered dose inhaler isn't exactly accurate or good. A spacer device helps, but just warn the patient not to clean up the inside of the spacer too vigorously or scrub it, as that may change the ionic charge of the spacer and then make it more or less useful. So a spacer device is a great add-on. There's another section as well in this doc that you can refer to, which is the nebulizer versus inhaler use. I generally like using the inhaler, as this allows patients or gives them freedom to move around. But some patients, again, nebulizer is the only way to go due to their debilitation or arthritis and so on. They're not able to use the inhaler well. So nebulizer works well in these situations. Again, take note that there are nebulized forms of the long-acting beta agonist, and their nebulized forms of the inhaled corticosteroid. So those are your options if you do use nebulizers. In any patient for COPD, just make sure you keep up with their flu shots annually, along with whether they need a pneumonia vaccine. So those are your general, I guess, housekeeping issues that you need to deal with patients with COPD. Now, something's kind of off the beaten track. If you have a patient that has maybe an asthmatic component to their COPD, for example, if they have had history of asthma or wheezing as a child, and they also have a history of smoking, you may want to consider increasing the inhaled corticosteroid component to it, because a lot of the COPD recommended inhaler doses are not the highest in terms of inhaled corticosteroid dose, while in asthma use you maximize the inhaled corticosteroid use. So in some of these patients that you start them on, for example, if you have the ICS LABA combo, you may want to go up on this dose, especially if you feel that's not being adequate in terms of symptom control. So that's a consideration. The other thing is also to add on Montelukast, which helps in terms of patients with an allergic component to it. The next thing is to consider sinusitis as a cause and to treat that. If they have chronic sinusitis, not just episodic once or twice a year, but chronic sinusitis that seems to contribute to their dyspnea or worsening respiratory status, a treatment with nasal steroids are beneficial. You can also use nasal sprays, nasal sinus sprays, just saltwater sprays, for example, such as the Ocean brand spray, and antihistamines. Also, obviously, the mainstay of most patients who have an allergic component or even sinusitis that needs to be controlled. Allergy testing as well is important, especially if you feel that there's an allergic component to it and it's still not responsive to nasal steroids or antihistamines. So referring them to an allergist at this point may be the next best step. If you think reflux is a possible cause of their worsening respiratory status or setting off their COPD exacerbations, referring them to GI may be warranted, especially if you've tried PPIs on them and they don't seem to work as well. So you may want to then at that point, if the PPIs don't work, to refer them to a GI specialist for possible pH monitoring. So that covers most of the outpatient COPD management. Thank you.